Bonjour, hello everyone. Welcome to day 2 of the conference. I'm starting off with an explanation for our interpretation feature. I'm just going to do a share screen for a minute here. Okay, great. Nous avons l'interprétation en français et anglais.
We have interpretation in French and in English. It's possible to click on interpretation at the bottom of your screen and select the language of your choice.
You can go ahead and click on the interpretation feature at the bottom of the screen, and you can choose the language of your choice, and you can change back and forth during the conference. A quick note that the conference will be recorded, and feel free to keep your camera on or turn it off during the conference. Nous allons prendre nous avons beaucoup de présentations pendant.
We have several presentations during the conference. And so if you wish to have a break during the conference, no problem.
A break at any time during the conference. And please go ahead and put any comments or questions that you have in the chat, and we'll be answering them during the conference, as well as asking the presenters at the end of their presentation. So great, thank you. So I'd like to ask one of our Dialogue McGill team members, Isabella, to go ahead and go over the land acknowledgement, please.
So, hi everyone. On behalf of the Dialogue McGill team, I'd just like to start the day by acknowledging that McGill University, where we are right now, is located on the traditional and unceded territory of the Kanien'kehá:ka. And this land has long served as a site of meeting and exchange amongst Indigenous peoples, including the Haudenosaunee and Anishinaabe nations. So we'd just like to take the time to honor, recognize, and respect these nations as the stewards of the land and waters on which we meet today virtually. And today, Jogjoge, or Montreal, is home to a diverse population, and we respect the continued connections with the past, present, and future in our ongoing relationships with Indigenous and other peoples in the community. So since this is the virtual event, we encourage speakers to deliver acknowledgements to the land that they might find themselves. And thank you for listening. I will pass it on to Professor Carmen Loisel to officially start this conference.
Thank you very much, Isabella. Welcome, everyone. Bonjour à toutes et à tous. Yesterday, we had a really great mix of international, Canadian, and local perspectives. And I think people enjoyed from the feedback we received. And today, the conference focuses more on Quebec-based initiatives. And it is really with great pleasure that I introduce a very proactive and a very engaged member of our community, Eva Villalba. So Eva Villalba is Executive Director of the Quebec Cancer Coalition, a nonprofit patient advocacy group dedicated to improving the Quebec healthcare system for people affected by cancer. Since 2008, she's been involved in numerous healthcare charities, advocacy groups, and nonprofit organizations. And the reason why we invited Eva to speak to us today is because she has amassed a large amount of knowledge on two concepts that are really important to us. The first one is value-based healthcare, and the second is how do we advocate on behalf of users of health and social services and patients, and families. So the title of our presentation today is Value-Based and Advocacy Approaches to improving access to health and social services. So welcome, Eva.
Thank you. Merci beaucoup. Je vais faire ma présentation en français aujourd'hui.
I'll make my presentation in French today, so thank you very much.
take questions in whatever language you like. Alors, bonjour. Aujourd'hui, je vais juste partager.
So hello, today I'm just going to screen share.
Voilà.
So here we are.
Alors, j'aimerais vous parler.
I'd like to talk to you about the approaches based on value and advocacy to improve access to social services and healthcare. So yes, I'll talk about advocacy as well as the healthcare based on value, value-based care in healthcare and social services that are of interest to us as well. And finally, all that has to do with the conference. So, Coalition Priorité Cancer in Quebec is the coalition of more than 65 organizations in oncology. All organisms are nonprofit, representing all types of cancer, all phases of the disease, all regions of Quebec. And we also have the rest of the Canada that's interested by this mission that we have, which is to improve the healthcare and social services in Quebec for the people impacted by cancer. So here are a few of our members. And our role is truly one of giving a strong voice to those people that are impacted by cancer. So it's a huge onus to represent all voices and not only those that makes the most noise, or the loudest, or the youngest. So why do we need advocacy? Well, ideally, we would not need an organization like ours because we would be equitable and the government would always make the right decisions for all, and we would not need advocacy. So let's take this example from Natalie, who lives in a region of Quebec, not in an urban center. She only has access to a regional hospital, and she has a melanoma. She's already seen some delays with her diagnosis because the physicians are only trained to detect the melanoma on white skins. So there were already delays in the regions. She does not have access, and she emigrated from a Anglophone country. So in the region, she understands French well, but not well enough to truly explain her needs. And she claims to understand what she's being told, but at home, she cannot make good decisions to have access to the services and treatment. She'll need to travel 3 hours in a hospital center, a university hospital center. So on those cases, we take for granted that everybody in Quebec may have access to all services that are already covered by our public health services, but truly there are inequities, and if nobody talks about it, well, we don't know that those problems occur on such a number of times. So what is the role of organizations or advocacy groups like ours? Well, it's to make sure that the voice of the patient and his family or her family be heard, and especially those that we forget or that we neglect, perhaps without any ill intent. And we are there to improve the public policies to bring solutions, and not only to complain or to identify issues, but also to suggest solutions in health and social services and that we can apply quickly out in the field with all players. And this is where I'm really happy to address you today, because we need a full ecosystem, of course, the patients and families, but also the health professionals, the researchers, academics, political decision makers, etc. And finally, the influence on the giving of the health care and social services. Well, so we need to have improvements based on what we hear out in the field. So we're truly there to get the voice of those people impacted by various diseases. In our cases, it's cancer, but it could be other cancers, other diseases, to have an influence on the health system. So how do we go about this? Well, in the associations, we often see physicians, health professionals, where there are issues in the systems. And when we get to a certain degree, they will go out in the media and talk about an issue. Same thing with some people in some families that can go to the media, but it's very difficult for one individual to move one big system. And the reason why the advocacy groups can help is that we have three influential keys by Robert Cialdini in his book on the influence. The patients group have credibility, authority, and the status to have some formal, informal power and some influence on the decision makers that individuals alone cannot have. And we represent many organizations, so we have more credibility than if it was just the one organization. When we are several of us, we have the strength of the group, and we can mobilize all of the actors to have a consensus and to truly get the influence to improve things for those people that we represent. So what are the tools that we use to reach our goals, to improve the public health policies and social services? Well, we use the interpersonal relationships, but we want to establish trust and psychological safety, security. I know that a lot of people know this concept amongst the patients, associations, health professionals, social services, researchers, and community. And we do this as we conduct governmental relationships. And what we often see is that the health professionals have great ideas. They are aware of what's going on out in the field, but they might not have access to do the lobbying, and it might not even be appropriate for them to position themselves in such a way. But that's our role, to bring all of those issues and as well as suggested solutions to the government, so we can truly say that we are a lobbying group on behalf of those people impacted by cancer. So it's our role to truly represent very diversified community representative of the patients and family that are impacted by the issues that we want to resolve. We conduct public relations as well, so it's a matter of raising awareness with the public and the communities to the essential matters. It's not necessarily the media relationships, but that's another tool that we could use. We try and use them well. We don't want to go out in the media every 5 minutes, but it's a good means to influence as much the government. When the relationship with the government don't work out the first time, we try and collaborate with the government and bring them the reality from out in the field. But sometimes it is necessary to truly mobilize all of the community to say, you know, there's truly a problem. I'll give you some examples that it's be your understand. So here are a few examples. So at the beginning of the pandemic, the coalition made 2 impact study of COVID-19 on people with cancer. We did it at 4 weeks and 9 weeks after the trigger of the pandemic to see what was the true impact of people with cancer, because at the beginning we were saying that there would not be any impact. So we saw that there was a huge impact on the mental health of those people impacted by cancer, because they had a double risk, a double fear and anxiety. One is that they were hearing that they were more at risk to catch COVID-19 and to die from it. So they were fearing for their health. And at the same time, they feared that if they showed up at the hospital or if they did not go to the hospital, treatments that they required to survive might be delayed, or it would impact on their prognosis. So what came of that is that we conducted a survey with 600 people throughout Quebec in English and French for all types of cancer. And with those 600 respondents, we lodged 14 recommendations to the government. So there were 11 out of 14, so 70% of our recommendations that were applied in the first month, within the first month. So we saw a very concrete impact of how we were able to influence the public policies for those people impacted by cancer. We also worked with other patients associations throughout Canada to mobilize all governments, but our mission is truly to improve the health services and social services in Quebec. So we were the only one that was in the group of Quebec, and we occupied a full page in the Global Mail to mobilize all provinces to prioritize a vaccination for those people that had cancer. Especially the youngest one, because they were saying if you're not 65 and more, you can wait. But the data showed that they were more at risk. And so we had to vaccinate them in priority. And so a few days after this big campaign that we conducted with other patients association, we did the governmental relationship work with Quebec. And just a few days later, not even a week later, we got news from Quebec that the cancer patients were going to be prioritized for vaccination. So we won that battle. And then from the very beginning, at our second survey, we've already seen that there was a major impact in the delays and the wait lists for surgeries, for the tracking programs and the early diagnosis, and people would not see people in the first wave. So there was really a delay. And what we heard from the people, the health professionals that we worked with, is that there was a real concern on the fact that we were going to start having cancer cases that were much more advanced because of the pandemic. And so we continue to conduct this lobbying to account to the population. And so we are having a meeting on Friday with this cancer program to put a bit of pressure on that plan. We were promised last June that we would have a plan that we do not have yet on the way to address this delays in deballasting that we had, because according to a researcher from McGill University, Dr. Malagon, we should be at 60% of our capacity to catch up on those delays, and it's not yet clear on how we're going to do it. So what's of concern are those people that we be targeted. So the minorities, those people that are already having access problem to our health care, and how will we be proactive in addressing and finding those people to make sure that they don't go through the cracks? Because according to a recent report from the Ministry of Health, in the first year of COVID, we would have lost beyond 8,000 cancer cases compared to the same dates of the previous year. So it's truly an issue of importance. And on that, we also participated to another campaign for advocacy throughout Canada with another group of patients. It's an initiative that's also international. It's called New Normality, New Normal Same Cancer in English. So it's to encourage the population. So it's a awareness campaign to avoid that the population will not wait until the end of COVID to make sure that their health is okay, or check for their health. And so we listen to our bodies, trust ourselves. If we are experiencing symptoms, go visit your physicians. That's advocacy, but there's another element that's also evolved in time a great deal, and that I want to mention, which is essential to our approach. And I think it's going to change a lot, even on how to avoid an abscess in the advocacy and the social services. So this is the approach with our partners that was developed at the University of Montreal by Pomme Marie Pascal and Al. So what's interesting is that you all know the paternalistic model that we used to have, where the doctor was king and a god. We never questioned him. They knew it all. It was the doctor. And we would not question and ever question that. So they already knew our needs. We would never ask for anything. We would just receive. So they were care to the patients. And then we went to an improvement, which was an approach focused on patients, a patient-centered care. So we always try to have that, think of the patient, and that was some type of improvement. But we would do everything for the patient, but not as evolved as what we're trying to have it now. And it's truly the partnership of the care, the partnership with the patient. So we include the patient. We recognize, first of all, that the patient is or her own expert in his or her disease. And we have to include that person in the decision. But in order to do this, it's essential to supply the patient with the information in a way that they can understand, and that the patient can communicate his needs or her needs. There are various levels of participations with the patients, and that's another referral scheme from the same doctor. And when we talk participation, we can go to the micro level. So myself with my health professional. So that is truly a partnership between myself and my clinician. You can also be a partner of care and an institution. So I participate in improving the health care and social services in my institution that's more at the network level, and meso or tactic. And at the macro or strategic level, you can avoid and re-facilitate the participation of the partner patient at the decision level. So at the level of the Ministry of Health, the cancer programs, the consult with INES, which is our assessment and medication organization, amongst others. And finally, the participation to research. So we are starting to see the importance and the added value of the partner patients in research. So I saw there were many researchers, and now the new approach is not only to conduct research on the patients, but with the patients, to invite the patient to participate with or in the research, to have that look and that expertise, to have it experimental, to experience the research out in the field. So this is my big favorite theme. It's the value-based healthcare. You might have heard of that. So what are those, and what does that represent? Well, if you are thinking about our present system and the basis for the decisions that we are making today, you see that normally we make a decision based on the cost, either that or the resources, what's okay for the system, sometimes based on what's good for the health professionals. But in that value-based healthcare, we are truly talking about determining the value and to make a decision based on the outcomes and in health and social services that are important to the patient. So outcomes that matter to the patients. So that means taking the time to ask the patients, apart from not having bladder cancer, what would be important to you? So it's important to advise the patient of the trajectory of the potential decision that can that will happen. But for instance, in a bladder cancer, you can cure bladder, the cancer, but you can have all kinds of other problems like that, ED or other. And so when we are talking about health care based on the value, we focus much more on the quality of life of the patient, not only at a very specific time, but on the full trajectory of the care. And when we talk about that, it's important to say that it's not only at the hospital, but also the full trajectory means outside. So in the community, at home, how can we improve the results, the health results, and provide the goals that that person wants to have, and the costs are measured. So the costs that have at present very important place. Well, to say that even if that medication is more costly or that a given test is more costly, to ask for psychosocial support earlier is more expensive. But if we are proactive, well, we'll avoid hospital stays or other issues later. So it's really a matter of looking at the cost on the full trajectory of the care. So practically speaking, what that means is that we put questions at the very beginning. So it's a team, a multidisciplinary team that is not only formed of the physician, but all of the health professionals that can help that patient. So they could be a nurse, a psychosocial support, oncologist, yes, in this case, perhaps physiotherapy, nutrition, and all of those people share the information. And so we ask the patients, what are the most important results for you to give you a good quality of life? And what's different, paradigm shift, is to not presume that the health professionals already know. And that is a way of having a better team. As a result of the replies that we get when we take the time to listen, and it costs nothing to take the time to put those questions at the very beginning, then we can plan the care path. So, for instance, to integrate a psychosocial support earlier, or adaptation to improve the results after a surgery, for instance. And the patient is truly part of the care, as I was showing earlier, with the partner patient approach. The patient has all the information like all other stakeholders, and you can make a decision, enlightened decision. And finally, you can only do it if you measure.
Typically, we're not very good at parts of this. So I'm using acronyms here. PROMS is patient recorded outcome measures. So patient recorded outcome measures. PREM is patient reported experience measure. And we're not talking about experience with the cafeteria. It's not a satisfaction survey about the services, but rather the care team. Do I feel listened to, taken into account? Or, rather what we typically do today is put the burden on the patient to, call when we get the patient to repeat their medical history, etc. And CROM is clinical reported outcome measures. So these are measured, but typically in silos. So a doctor will have clinical reports, nurses, psychosocial supports, also they each have their own data, but we're talking here about sharing the data with the patient and amongst the care team. What matters here is that we readjust the care path in function of these results. So if we have distress, we can act upstream before the person is in a crisis moment at the emergency room, and we can apply the data in order to improve the care path. Why is this important? Well, I mentioned it a bit before. It allows us to have better equity. So this truly is an approach based on individual needs for all. And it's a way to be more equitable, especially for people who are underrepresented. This allows us to have a holistic vision of the person and their needs. It allows us to better integrate mental health as well as social determinants of health. Yesterday, we talked a little bit about mental health, issues with access. So this approach here, value-based healthcare, allows us to look at the whole person. And of course, mental health is part of this scheme. So we want to have on an equal footing physical and mental health. There's also a care path beyond the hospital setting, and we want to value preventive interventions, early interventions, and social interventions if they can improve outcomes. What we want here is for, well, this is summarized in this quote that you see on the screen. So each should have a fair chance to achieve full health potential. So concretely speaking, no one should be at a disadvantage in achieving their full health potential. But as we well know, who is heard? Well, of course, it's the majority, whether in Quebec or in Finland, in Canada, whichever, the dominant majority decides on policy. It's people who have power and who are privileged. Those are the people who shape public policies, those that have a better network and can mobilize this network, and those that are proficient with communication and have the resources. And this is where advocacy groups can really help the people who are not well represented to be better heard. So when talking about representativeness, there are issues with regards to the type of disease. So in oncology, some cancers receive more attention than others. It could be some diseases that are stigmatized. It could be rare diseases. So these people are underrepresented. We take into account geography. Of course, people in more remote areas have less access than people in urban settings. We mentioned yesterday some social determinants of health, and what especially is important here is underserved and marginalized communities. And of course, we cannot forget the tragic lesson that we experienced with Joyce Echaquan last year. It showed us how we completely dropped the ball with Indigenous health and our public health system. But everything isn't bad. We do have opportunities, issues and opportunities both. So this is my point of view about this. So how does this, concern us about linguistic minorities? Well, to be a partner or to be part of one's own care, we need to have some level of medical literacy, but even more basic than that, we need to understand what is said to us and to be able to express ourselves in such a way that our wishes and our health measures are well understood. So it's essential in this care partnership and for the empowerment to have this communication. We want patients to give an informed consent and to take part in the decisions relating to their health. Currently, if we don't recognize the importance of linguistic minorities and their obstacles in being expressed and in understanding what relates to their health, then we're really not on the right track. However, we have the tools. In each health facility under the responsibility of the health department, I'm especially interested in oncology, but a few years ago, the government set up some offices related to the partnership. So they're typically affiliated with the quality department of health facilities. This is a very practical tool to integrate patient partners in a facility. And we see representativeness is truly essential. If we have always the same people, then informing this, of course, will always cultivate the same issues. So this approach is one that the health department is trying to adopt on a larger scale. We're maintaining advocacy there in order to push them in the right direction, making sure that they're accountable with regards to this. But still, they do have frameworks to apply this approach of partnership care. And more facilities are applying this framework. We also talk about values. It's important to acknowledge unique needs. So in order to assess value for the individual and for the system, in the context of value-based healthcare, what is good for the patient is also good for the system, because the patient doesn't want more services. The patient wants to be healthy. No one wants healthcare. They just want to be healthy. So anything that's good for the patient will be good for the system. However, not so in vice versa mode. This means that each individual must be cared for according to their needs and their objectives. We can't think of people or patients as one homogeneous group. We need to take the time to ask the person, for instance, let's say a 35-year-old woman who has breast cancer. She's going to undergo some procedures, and we have to explain the various options, either removing the breast or another type of surgery. How will this affect her fertility? So in Quebec, we may have a co-fertility or fertility preservation services. So should we assume that because she's 35 or 38, that she doesn't need her fertility anymore? Do we assume that she doesn't want children because she's single? We should take the time. Perhaps she won't want, perhaps yes, but we need to take the time to ask, is fertility important to you? Because we can offer services to preserve fertility, as well as psychosocial services, physiotherapy to make sure that you can walk well and continue running races as you used to do before. But we should never assume. We need to have these conversations. In wrapping up, this is a quote from Antoine de Saint-Exupéry. It says, in life, there are no solutions. There are only active forces. They must be created and solutions will follow. So today, I think you're mobilized to really give an impulse to these active forces and act together. And here are some references. Thank you. Thank you, Eva. There were a lot of questions relating to your talk, so we'll have a look at that.
The simultaneous translation. Alors, la première question, c'est de Marilyn Kaplan.
The first question from Marilyn.
Given your successful advocacy role and large community that you represent, have you considered the potential impact in terms of quality and safety of Bill 96 on this population?
Yes, we've considered it. So I think that it's going to be really important to have our ear to the ground and to work together with key stakeholders, whether it be healthcare professionals, community groups. We're always open to hearing about different challenges happening all over Quebec. and we really make an effort to not be Montreal centric, even though we are in Montreal. We really want to hear, especially in the regions, if there's specific issues, how we can do something about it. And we do have the openness of the health minister's cabinet, for example. And so if there's some concrete issues, some access issues, that is something that we would absolutely mobilize for, and make sure that that this percolates up to the necessary decision makers.
Thank you. The next question is about the survey you did during COVID. So Jennifer Johnson is asking, did you analyze the results of your survey of individuals with cancer and the impact of COVID by language? If so, did you see differences between the language groups, French and English in particular?
I have the data, but we didn't see any obvious differences, but we still have them, and I can always look at it again. The vast majority of our respondents in English were in Montreal. In Montreal, it seemed like it was more of a difference between the regions than with language at first glance. But I could take a look at it again. There was nothing obvious according to language.
Thank you. Then there's a question from Jessica Sinat. It's how are your services promoted in the regions?
So we don't provide any services. We do the advocacy, but our groups actually are in the regions. Some of them are regional, like Cancer Saguenay, for example, or l'ASEC, l'Association du Cancer de l'Est du Québec. So they're members of ours, and our role is to actually promote and elevate the voices of our member organizations, the community groups that are there locally, and also to encourage the healthcare system to refer to community groups that can actually help their local population. And so, you know, all our organizations are listed on our website, and we have their emails. When patients call us directly, I'll listen to them, and then I'll refer them to the appropriate resources in their region. So I hope that answers your question.
Thank you. So, and then we have a question from Juan Carlos, who says, cette stratégie dépendra de peer support.
The strategy will depend on peer support. Perhaps, Juan, you can come on and explain what strategy you're referring to?
If it's clear, then we won't need the... So, autres personnes affectées par une certaine condition ou autres...
For people affected
Je ne pense pas que l'État pourra fournir des
by health navigators. It's community organizations. So this is a question. So does it mean that community and volunteer organizations have this this responsibility of peer support? Is this am I understanding the question right? Juan Carlos, you may intervene if you like.
I think my question was especially about a value-based strategy for patients. To have an advocate for individual patients, it requires somebody who knows their situation well. So it's just trying to understand how that could play out across the province for, let's say, 1,000 people with inflammatory bowel disease or diabetes or a cancer. And so I was trying to understand if this going to necessarily depend upon community organizations that have been, I guess, trained or taught more about this value-based system approach.
Yes. So the value-based approach, contrary to the patient partner approach, which is really an individual approach. So the patient partners, and there have been peer, and in French at the CHUM, they're using des patients accompagnateurs, or patient. That's a very hard word to translate. I don't know if the translators can help me. Accompaniers, it's terrible.
Patient navigator.
Yeah, it's not exactly a patient navigator. That's the hard part. And so they basically This was a breast cancer pilot. They had actually put someone who had already gone through breast cancer with a new breast cancer patient, and they weren't helping them to navigate. They were literally just supporting them along the way, just having someone that has shared that experience with you. That was shown. Maybe it's hard. It's not even a patient coach. It's a new concept, so it's hard to and the semantics are difficult. But anyways, that was one type of peer-to-peer support that's integrated into the hospital. Now, when I speak about value-based healthcare, just to clarify, it's not on an individual level at all. We're really talking about a different approach, which promotes healthcare transformation. It's actually an approach on a systems level. Is how do we design healthcare services to deliver the best outcomes to patients over the entire trajectory of care at less cost and using less resources. But really, ultimately, the primary goal is to proactively improve patient outcomes beyond the very binary cancer, no cancer. Like, how do we make sure that we make people well and not just not sick, which is really our current approach. And so it's, buddy is good. So I guess it's like a buddy, that patient accompagnateur. It's more like a buddy, and it's more like a psychosocial support. And it's just someone to be there with you. Doesn't necessarily have to, they actually don't have to have the clinical answers. They're really just there for emotional and moral support. And you feel a sense of trust because they've also gone through it, and you don't feel so alone. So it addresses that isolation. But that's at the individual level. So really, just to clarify, that the value-based approach is, as healthcare providers, you can absolutely just start thinking in those terms. What does wellness mean for this person? Not just not sickness. So actually, how do we make this person well? What does quality of life mean for this person? And not just how do we get rid of this cancer? And so that's really value-based care. So we don't need like an individual advocate. And actually, we as a larger advocacy organization, we actually promote this approach at the higher, ministerial level, with success. They are starting to look at this, and I think I skipped it earlier, but a few weeks ago, the Quebec government had a new law, the PL 19. So it's the law on health data. And one really good thing that came out of that is that they did consult patient groups. We were very active. We submitted a brief. We will continue to be active and really making sure that the patient voice got heard in this new health data law. And that will actually help to make sure that patients have their own data. And I think that will help with equity and access problems, even for language minorities, in the sense that communicating that information over and over, having difficulty accessing your own health record, and then having difficulty expressing that to multiple providers, that will be helped by having all the data centralized. And if someone collected it well somewhere, you don't have to repeat it. It's actually in a centralized system that all of your healthcare providers, not just doctors, but even the psychosocial help or the rehab, nutrition, everyone can have access to that same data, and that will actually improve access and equity, especially for language minorities, I believe.
Great, thank you. So lots of questions and comments. So Julia is saying that she says, thank you so much for the work that you do. I am inspired by your presentation. This advocacy work might and should be extended to other healthcare domains, a good model to follow. So, and I totally agree with this. So Eva, any collaborations with other groups with different health issues or challenges that you've initiated or are planning to initiate?
So we do work with, for example, in November, and I'm part of this larger working group actually applying value-based healthcare even to other disease areas. So there's a really good annual conference in November called Patients Redefining Healthcare. And it's not just for oncology, it's for all cancer types. So there's patient advocacy groups all across Canada. And we get together and we talk about, general issues. Like this year, we had an entire day on Indigenous health and better understanding, the different, not just the inequities, but also what we can learn from Indigenous communities and how they've reacted to COVID. And so, much larger public health kind of scope. We have groups with chronic diseases that we collaborate with. We have mental health associations that we collaborate with. So we do try to share and mobilize and work together as much as possible. To my knowledge, there's no similar organization to ours in other disease areas. I know that mental health does have and like caregiving has some sort of coalitions of different groups, but we're happy to collaborate with any others and share some of our expertise and networks, because the networks really help to get things done.
That sounds like a great plan. So we have another comment. Jim Carter comments that yes, community networks can be health navigators. And he says we have some good examples of this role. And I guess you've been working with community networks too, Eva?
So it was interesting because I listened in yesterday to your conference, and we haven't actually. We work with community groups, but we haven't yet worked with community networks. So this is the invitation. Please, I would love to work with community groups. I think that it's an untapped resource, and I'm always open to seeing how we can better serve, people affected by cancer in our case. But I do think that it would be a great collaboration. I think that it's an untapped resource, and I would love to work with you all. So please contact me.
That sounds good. And I think Dialogue McGill can facilitate this. So we'll be happy to. Thank you. So, merci pour votre, I just have to see who, Marie-Brigitte, merci pour votre présentation intéressante. Comment considérer...
Thank you for an interesting presentation. How can we consider in our public policy the singular needs of specific minority communities in a universalist world? Well, I think we can have public policies that are flexible enough and that do acknowledge diverse experiences. So we're not trying to apply a cookie cutter approach, one size fits all, but rather I think we need to adapt the model in order to recognize the needs. And honestly, the only way to achieve that is to ask, to take the time to understand the needs. But upstream, we need to recognize that there are needs and problems, like systemic racism, for instance. So only by acknowledging the issues can we then have options, alternatives, and solutions. We truly need to take the time to survey people and understand the whole diversity of experience that exist to answer these needs. Great. We have a question from Fatia. Have you knocked on the door of the community groups that participated to your survey, that filled out your survey? Well, yes. We have 67 organizations, nonprofit organizations that are part of the coalition. They're the ones who helped us get some respondents to the survey. So with these organizations, we got a lot of help to get respondents, but not necessarily with other groups outside of our membership. We did try to do this, in just a few weeks. This was in April, and we were trying to get the survey out quickly. So it was difficult to mobilize people at this stage, but 600 patients is pretty good. Yes, we have a comment from Lise Richard. It says, for Newfoundland and Labrador, the health authority has added a position for patient navigator In Ontario, we see the same role in a community health center. So there are places where we do have patient navigator positions that are added in a specific language. So in this case, French speaking. So yes, having a patient navigator who speaks their language can be very helpful, of course. But if we have a navigator without looking at the needs of people and the needs of this individual, we're not in such a better position. So we can take a person by the hand and help them navigate the care path without them having their part in decision making, then we're not quite there yet. And we need to improve participation of the patient to their care path. Yes, and Lise Richard adds that yes, this is very important, and we have navigators for mental health, for cancer, and for Indigenous people. Fantastic. Any last minute comments or questions? People are welcome to add them to the chat. Otherwise, we're just 3 minutes away from 10 o'clock. So we're going to move to our next topic in just a few minutes. So really, this was so on point. A lot of people had questions and thoughts to share, and hopefully possibilities for collaboration. Thank you so much. And we'll see you, Eva, very soon, hopefully. And I hope that you'll stick with us for the rest of the day. Yes, of course. Thank you. Thank you so much.